Hi, can you guys hear me? Hello. Okay, thank you, Shahir. Okay, so thanks for coming. Yeah, we'll be recording this session. So if you guys need to like go back and look at it, feel free. We'll send you the link later on. So I'm just gonna introduce myself again. My name is Dr. Abigail Tan. So yeah, and I took the NCA this year in 2020 in November. So these are quite fresh in my memory. I'm just going to tell you my experience in how I prepare for it. I did pass it, so thank God. So I hope this will be helpful for you guys. So the agenda for today, what we are going to do is I'm going to just briefly talk you through what is the NCA, who needs to take it, where is this held, and how many stations. And there are 12 stations in total since COVID, there are 12 stations. Before this, there were 16 stations. And since there's 12, it means you need to pass, like, you can't fail as many as before. I hope you get what I'm saying. Yeah, so yeah. If you guys have any question, just raise your hand or shout it out, or you can put it in the chat. I'm able to look at it today. Okay, so moving on. So NCA just stands for National Clinical Assessment. Uh, who needs to take it? So basically, anyone who graduated from the day you graduate, the formally documented date which your university will give you to the date that you are going to start work, that will be calculated by the UKFPO office when you put in your application for the eligibility. If it's more than 2 years, or as long as it touches 2 years or more, then you will have to sit for this exam. If it's less than that, you can just forget about it. You can just go on to moving on and take the SJT and get offered a job. That's all. So, yep. So in 2022, it cost £850 just for the exam alone. It's in this hospital in Manchester. We honestly, I have no idea how to pronounce the name. I just think it's called Withen Shawi Hospital. It's in Manchester. It's right in the city of Manchester. It's very convenient to get there. So, like I said, in 2022, there were 12 OSCE stations, and they only expect you to perform at the level of a FY1. So, don't expect things that are too difficult. They are not actually looking for people who can manage a case on their own. It's not like a MRCS exam where you are already going into a ST level. You're just going in as a F1, and they want to make sure that you are safe in UK at the UK standard. So as long as you can reach that, you will pass the exam. Of course, there were people. I've joined a Telegram group, a worldwide Telegram group. Of course, there were people who failed it. So yeah, just try and prepare properly and start early. Okay. So just some basic information. I hope these are practical tips that will help you where to stay. Like if you do need to go, I hope you can look back at this presentation and know, like, then you do not need to source for hotels, like bus. Those are small things which you could be using your time to study actually. So I stayed in this IB Styles Manchester Portland Street. So it's a 3-minute walk from Charlton bus station. If you're gonna take the bus from London to Charlton, to Manchester, you should pick the destination as Charlton bus station, and then from there you can just walk to this lovely hotel. It's quite reasonable, even in ringgit. It is very reasonable. It's about 2 to 5 minute walk to four different supermarkets. So if you're hungry, you can just get something to eat. You can walk to the hospital from here. It's about 30 minutes. Uh, if you're going for your exam, I don't advise you on your route to the hospital that you walk, but you can walk back after your exam, like go there early, take a cab there, just get there early. Don't stress yourself out so much. And then when you're back, you can take a nice long walk along the street of Manchester, and then you can have a look, explore a little bit. And if normally the exam takes place in November. So the Christmas, when I was there this year, the Christmas market was already set up. It's just 2 minutes from the Christmas market, so you can drop by after your exam and have a look. It's really beautiful. Okay, so you can see this information for candidates. When you sign up for the exam and you've paid for it, they will release this information called information for candidates. So basically, they're telling you where is it, how to get there. Basically, what I'm also telling you, but in a more detailed fashion, obviously, and what is examinable and whatnot. But those are very detailed. I'm not going to go into that because they can already give you, but more I'm giving you how did I prepare, like practical experience from my side. So getting to the hospital, like I said, you can walk, it's about 30 minutes. You can take a Uber, it's like 7 to 15 minutes depending on traffic. You can use either Uber or Free Now. uh and then how to get from London to Manchester, because that's how I flew into London and then I took a bus to Manchester. You can take a bus, it's only £20 for a round trip, or you can take a train, which is £70 at least for a round trip. So plan your timing properly. The bus can be a little bit uncomfortable. It's 5 hours. It can be quite cramped. The train, of course, is much more comfortable, but it's much more expensive. And recently, there has been a lot of strike going on in with the rail services. So if you in the future, do check the timetable if there are strikes and anything going on. So this is the map of this within Shawe Hospital. As you can see, it's actually really big. Okay, so in your information from candidate, which is this document, it will be clearly stated where is the exam venue. For my year, this year, it was quite a big cohort. So there were 2 locations. Although they were really close to each other, you had to report, like different groups of people had to report to different building, although they were just next to each other. So when you get the list of where you are going, the please look at the map, look carefully, like explore it, like just make sure you know where you're going, and then be early so that in case if you turn up at the wrong place, you still have time to go to the other place. Know your timings. The exam, uh there are morning session exam, so if you are in the morning session, there you go and get it done. But if you're in the afternoon, then you be there in the afternoon. So know your time so that you don't miss out. If you're in the morning and then you thought you were in the afternoon, then you they will not entertain you if even though you are there in the afternoon. Be early, like I said, in case if you mixed up the venue, you can at least uh just hop over to the other building. There were people who actually went to the wrong place when we were there. Thank God they were early. They were like half an hour early from the registration time. So yeah, we heard people going to the wrong place actually. So I'm just gonna show you what are the resources for the NCA that I've used for my exam. If you try to look on Google, there's actually this exam is almost does not exist in Google, honestly. Only Sharishka Singh, which I'm going to tell you she is. She's really good. She actually put up very good resources. It's like the Bible for NCA. She is really good. And then there are a few videos, odds and end videos about the resources they use. You can just feel free, check it out. These are people who have passed the exam as well. So Sharishka Singh, she's a doctor in the UK now. I think she's doing internal med, or I can't remember what was she doing, but she's already quite senior. She took the clinical assessment and she wrote a book actually. This is your Bible. You must read this. I think I've read this book, like it's a PDF. I can send it to you guys. It's a PDF. It's about 50 over pages, but it's simple reading. She has so kindly like put together all the resources of what they expect you on the NC on a very, very good level. So she also has a YouTube channel. I have linked it here for you. She did run some classes and courses for NCA for the past few years, but this year she did not run because she was busy with her training and whatnot. But she uploaded some of the videos, so you guys can have a look. Very, very good videos. Once you look at the video, you will have a clearer understanding of what each station entails. She actually gives like scenarios for volunteers to act out and whatnot. Okay, this is my own resources. So the resources, the first resource was Sharishka Singh's PDF. The second resource I highly recommend is Geeky Quiz. Okay, it's not Geeky, it is owned by Geeky Medics, but it's another website called Geeky Quiz. For these resources, you have to pay. I can't remember how much. I think it's like less than 50 US dollar or something like that. You just have to check it out, but it's really good. Yeah. So what I like the most about this is it prepares me for the ABCDE assessment a lot. I don't think I was actually properly taught how to do a ABCD assessment in medical school, and also in my master's in RCSI. Like there wasn't like a practical session of like detailed ABCDE. So I think this page really put it together for me, like how should I organize it and whatnot. So these are just the Geeky Quiz works as they provide you with a ton. It's all OSCE stations only. Geeky Quiz website is only all OSCE stations. So, and it's divided into emergency, medical, surgical, ortho, and whatnot. Different categories, but they are all OSCE stations. Okay. So I've screenshotted an ABCDE assessment OSCE station of a chest pain. So yeah, so this is the stamp that they will give you on the instruction. So you've been called urgently to a surgical ward to review a patient with chest pain. Please perform an ABCDE assessment and implement management as soon as possible. This is something that actually resembles the NCA's A to E assessment station a lot. Okay, it's just a very simple thing, FY1 final met thing. So yeah. So in the Geeky Quiz, it will show you. So if you have this Geeky Quiz, you can get 3 people together or 3 students. One can be the student, one can be the patient, and one can be the examiner. Okay, and then you can either print out or give each other the instructions, and then you guys can practice. But if you are just alone, like myself, it's fine. You can also just read and visualize in your head like what you would do. Okay, so first I'm going to show you the same OSCE case, but patient's instruction. So they will give, if your friend or you are playing the patient, you can know how to react, how to act out. They will tell you like the patient should be sitting up on the bed, alert, responsive, and whatnot. Okay, I'm just showing you like a part of the patient's instruction. It's really long, as you can see here. So if you go through it, you can have a look. Next is examiner instructions. I think if you're alone, you don't have people to practice with you. This is the best. I only read examiner instructions all the way. I memorized them. Like understand the concept and memorize. Like don't memorize it like just um like blindly memorizing it, you know. Like if it's a chest one, like airway, what should you do? Breathing, you must check the respiratory rate. Then for chest pain, the most important is circulation, so heart sounds, JVP, and whatnot. So examiner instructions are really good when you are just alone practicing for the NCA. They are very organized for all OSCE stations. They are uniform throughout all OSCE stations. Okay. So that's about ABCD assessment. I'll talk more about it lower down. Okay. So as for the format, you will have 90 seconds to read the instructions outside the station. And then if you need to wear PPE, they will put it there. It's so obvious, like you have everyone is in the room and it's all by blinds. It's not like rooms. I think it's the same with like what we do in RCSI. So you're in a big hall and then they put the screen. It's like screen 1 for one station, screen 2 for this station. So you go there, you will be able to see which station that you will need to put a PPE. So even before you arrive in that station, you already know which one you need to wear PPE. It's just an apron and gown, that's all. Usually it's in the examination station that you will need to wear PPE. So yeah, 90 seconds to read the instruction outside. Then they will, on the intercom system, they will say enter station. So you go in the station. You have 9 minutes to do whatever you are asked for. This is uniform throughout all the stations. Then they will also, again, they will announce on the intercom system, 2 minutes left. So you know you have 2 minutes left. And then they will, later on, there will be a beep. Then you should know in your mind that you have only 1 minute left. And then someone will say it on the intercom system, when time's up, please move on to the next station. It's very straightforward. So basically, you have 9 minutes only. For the results, this year's exam took place on the 7th to the 10th of November, and results came out on the 23rd. So it's around 2 weeks for you to get, and they will give you the results to your registered email, and they will actually give you feedback, like what you did well, what you did not do well, which I think I really appreciate. For the £850 that I paid, I think I should be given feedback. There is an appeal process in the event if you fail. However, I do not know how does that work, because I didn't go through the appeal process. But just know that there is an appeal process in the event you need to use it. This is also one of the documents that are released to you when you've made the payment for the exam. So my own experience, it was very, very nerve-wracking, because for me, it was everything. I really wanted to go to the UK. I did not want to do my housemanship in Malaysia anymore. Like, I just didn't want to. So my whole life kind of depended on it. So I was really hyperventilating. I had to take a beta blocker to calm myself. So after going through, I would say just calm down, take deep, slow breath. Although you are very nervous, just try to calm down and get your composure right. Next, if you're worried about how the flow of the OSCE is going to go, like where are you going to go? Am I going to go to this station or what? Don't worry. There will be people, there are a lot of staff on site on that day. They will tell you where to go. They're very nice. They even have provided us with water. Like there are 2 rest stations for me. So they even provided water and whatnot, because after talking and breathing, you're very thirsty. So don't worry, they're really nice people. If you think you've done well or you've done poorly in one of the stations, just after the 9 minutes, shut it down and move on to the next station. Don't let the previous station affect your subsequent station. I tried to do this because when I first went in, my first station was an A to E assessment. And because, like, it's a first station, like, you don't really know what's the feel of everything happening around you. So I think I fumbled quite a bit. But then I was trying to tell myself, like, there are 11 stations more, so just move on, forget about it. It's happened. I can't change it, but I can change what's going to happen before. So my greatest advice to you is just move on, forget about what happened in the last station, start afresh. Next is, I think this is a very important advice which would carry you all and carry all of us until we are a consultant. Be very systematic in all of your presentation. Like, if the examiner asks you, so how are you going to manage this patient with a chest pain now? Go in a very stepwise fashion. Everyone develops their own style or categories of how they want to do it, like the ABCDE, or it's fixed: airway, breathing, circulation, disability, and exposure. In everything that you do, try to find a system. Yeah, because in medicine, in surgery, it's all about systematic. So now it's a time, try to hone your skills, because this will carry on until when you are taking memberships exam. It is the ultimate thing that they want to see. If you are systematic, you won't miss anything, and they will give you very high marks if you are able to do that. So yeah, these are just my own 2 cents. So I'm just going to talk about the first 6 OSCE stations. The next session that I'll be talking is about the second half of the remaining 6 OSCE stations. Okay, so the first 6 that we are going to talk today is focus history taking, examination, safe prescribing, recognition and management of acute illness, surgical and perioperative care, and discharge planning. Okay, so for the first OSCE station, this will come out in your exam. So history taking, 2 stations normally, 1 psychiatry, you're almost guaranteed to get 1 psychiatry case, and the other one will be just a regular history taking. Okay, so what do they expect from you is systematically pain. Use the Socrates if you're comfortable and if you're trained in it. I was trained in RCSI, so I only use Socrates if there's pain or anything. Okay. What they expect you to do is to catch the diagnosis. You can just tell them, my diagnosis is this, and you explain why. The diagnosis will be very, very, very clear cut, because this is just an FY1 exam. They are not going to give you some weird thing which are and with signs and symptoms that overlap with cancer. Like if the patient is having heart attack, it is a heart attack. They will not put in pneumonia and then what they call that pneumothorax, like very vague symptoms and history, like it's just there staring at you. So be able to catch it. The patients can have hearing impairment, like the SPs can have hearing impairment, any speech language problem, or mental health problems. Mental health problem will come under the psychiatry case. So if the SP is having hearing difficulty, you can ask them, do you have a hearing aid with you? Then they might tell you, oh yes, it's in my pocket. Then you can just tell them, can you please put it on so that we can talk properly, or we can talk clearly. Just say it. Yeah. Okay, so yeah, there will be usually 1 psychiatry case and 1 regular history taking case. So just be systematic. Remember, you only have 9 minutes, so you have to be systematic and very fast. Okay. Psychiatry, history taking, I think a lot of us, by the time we reach the NCA, we would have left psychiatry quite some time, because we are, psychiatry is being done in SC1. So I definitely forgot most of my thing. I had to go and dig for all my books again. So after going through reading and looking at our RCSI resources and whatnot, it's definitely manageable, not difficult at all, very obvious diagnosis. Depression, these are the top 5 things that usually come out in this exam. Like Sharishka Singh, actually, she managed to, I don't know where she gets, she has a resources of all the passive, but anyway, these are the top 5 that usually comes out, like depression, anxiety, schizophrenia, bipolar eating disorder. So just memorize or know the criteria for depression. Like depression is decrease in mood, decrease in energy, decrease in what's the third one? Decrease in mood, decrease in energy, and low concentration. And then they are like the other sub symptoms and signs and symptoms. Just know them, and then the minimum time is like 3 months of low mood and whatnot, loss of concentration. Just know it. Then the moment they tell you what is their signs and symptoms, you can already pinpoint that it is what it is. They will literally write the station in a way that fits the criteria of a diagnosis of depression exactly like how it is, because it's just an FY1 exam. You're not taking a psychiatry exam. Okay. But the most important thing of all, okay, fine, you've taken the history. I have low mood, low energy, low concentration, and blah, blah, blah. The most important thing you must do in the 9 minutes is you must do a risk assessment for psychiatry history taking. So you have to ask them risk to themselves. Do you have any plans of killing yourself or hurting yourself? Then risk to themselves, risk to others. Have you ever thought of harming someone else? Then what about what do you call it? Risk to themselves, risk to others, and risk from others. Like when they have this kind of episode, is their job threatened? Like is their boss looking to fire them? Like you can just ask them. But most important, you must ask is suicide. Do they have any plans of killing themselves, hurting themselves? Have they made any plans yet? Have they told anyone? Risk assessment is something that you must do. If you don't do, I think it's a very big offense and you might actually fail this station. So just do it. And the patient might ask you, I got asked, why do you ask this question? He got really upset. Like, why are you asking me? Is there something, do you think I'm crazy or something? Then I said, no, it's just a routine question. And then he was like, oh, okay. Yeah. The patient is really good. Like I said, very obvious diagnosis, only 9 minutes. So FY1 level. Second station will be examination, like physical exam. So all systems are testable, medical, surgical, ortho. They can be real patient with real findings, or they can be just a simulated patient. One of the OSCE stations was a spine exam. The patient could bend better than me, to be honest. So go in, put your PPE, go in, introduce yourself, examiner is there. Then she will just give you a stamp, please examine this patient. Just go to the core of it. Peripheries, not as important, but you must examine, like if it's a heart condition, just go straight to the heart condition. Okay, don't go at the peripheries, eyes and mouth and tongue and chest and whatnot. Just go straight to what you have to do. If the patient comes with suspected appendicitis, straight away introduce yourself, go palpate the abdomen and feel for the organs, percuss, auscultate, do your elicit the signs, and then if time is not up, you can do all the other things that you want to do, hands, eyes, neck, and whatnot. Okay, yeah, this is quite straightforward, but try to do it well, do it fast, practice at home. Geeky Medics has a lot of good videos, so you can try or practice with your friends as well. Okay. Third is safe prescribing. I think this is a bit different than the exam that I had in RCSI when I was in IC3. But anyway, it is manageable to learn. It's quite straightforward. There are three ways this station can come up. One, they will ask you to review a cardex. This is called cardex. Cardex is basically what they write, like every doctor who prescribed for this patient, they will write on this booklet. It's called cardex. So basically the three tasks that can occur in this exam is one, review the cardex. So they can put there, and then one could be missing a signature or one could be given the wrong route. So you must be able to catch that. Okay. Secondly, they can also ask you to take a full medical history and then complete the cardex. Okay, so you have like, it's only 9 minutes, so probably they will only give you a very uncomplicated patient. Take the drug history and fill in the cardex, like what would you give this patient now, that kind of thing. Sometimes they can give you fluid management as well, but it's very simple fluid management, like calculate maintenance for this 70-year-old man. So you should know, like 70-year-old man, you should give, you can calculate according to their weight, either using the 4-2-1 rule, whichever that you are comfortable with, but you should not give more than 3 liters, definitely. Yeah. Allergies, very important. You must be able to catch allergies. If you're taking a history, you must ask about allergies. Good news is the exam is much easier than the PSA exam. PSA is actually, I did go through the PSA in preparation of this exam. PSA is much harder. There's so much of technical details that you have to know. In the NCA, as long as you're safe, you write the name, the route, the dose, you sign, and then you write, yeah, just once you do all that, your own name, patient's name, allergy, you should be able to pass. Okay. And then in this station, a BNF will be given. This is a BNF. There's a physical copy and there's an iPad version as well. Both will be given in the exam. I highly recommend that you use the iPad. It's much better. Okay. So if they give you a stem like this patient is having asthma, an asthma attack, please prescribe medication for this patient. So obviously everyone knows it's salbutamol, 5 mg nap. Okay, even if you know the dosage, you are so confident with the dosage, you please don't, before you even look at the BNF, please don't write it, because the examiner is sitting right next to you. They are looking what you are doing. You must demonstrate that you've opened the page of salbutamol, look that this is for asthma, it's 5 mg nap, then you write it down or tell the examiner, I want to give this. Do not just go in and like, oh, I'm just going to give salbutamol 5 mg. They will fail you if you do that, because you are just an FY1 level. They don't want doctors that are doing things by themselves or being too smart. They want you to be safe. So everything, check the BNF. Okay. This is very important. Yeah. The fourth station is recognition and management of acute illness. So basically like heart attack, what more? Pneumothorax, asthma. Okay. So in 3 ways this exam can occur. The first is history, exam, and management, whereby you take a history, you do the physical exam, and then you discuss the management with the examiner. The second is you do a history, tell the examiner what you want, what investigations you want, and he will give you whatever you ask for, and then you guys discuss there. Okay. The third would be A to E assessment. I believe A to E is the easiest, because once you have a fixed format in your head, you've practiced it enough, just go in, pop, just say, okay, I'm checking the airway. I'm looking at his mouth. There's no foreign object. Patient can talk. I'm moving on. Just vocalize everything that you're going to say. Say everything that you are thinking in your head. Then you will score marks. Don't be on the fence about trying to say things or not. Just say everything out. If you want this investigation, just say it. Because if you don't say what investigations you want, he will not pass you the paper. So then you might miss out very crucial information in it. Okay, so type 1, take the history, do the physical exam, and discuss the management. But you only have 9 minutes to do 3 of these tasks. So you must be very focused. Peripheries, like I said, it can be very brief, provided if you think the peripheries, like if you think the pulse is very important for for any specific diagnosis, then you can take the pulse and whatnot. Then you discuss the management. The doctor will say, so tell me what's your management. Then you can start with, I'll start on 15 liters non-breather mask, oxygen, 2 large bore IV cannulas, monitor input-output chart, and whatnot. Have a system when you say all this, because these are acute management. You can have a system of doing it. Yeah. Type 2, so it's, like I said, history. Then tell the examiner what investigations you want, and then discuss with the examiner. So take a focus history. You must vocalize what investigations you want to do. I want an FBC, then they will give you. I want UNE, then they will give you. Okay, like I said, you will only get what you ask for. If you don't ask for it, he will not pass it to you. Okay, then you're asked to interpret the results. Of course, it'll be very, very obvious. If he is like anemic, it's going to be like low. If ABG is like off, it's going to be either grossly acidotic or grossly alkalotic. Then you might be asked even to explain to the patient what has happened. Like I think one of the, like previously, if I remember correctly, was like, you go in, you take a history, the patient was coughing for a long time. She collapsed, she came in, chest x-ray was done, chest x-ray was given. Chest x-ray was given to the student, interpret it, and then the examiner told the student to please explain to the patient what do you think is it, and what is the further management. So yeah, it can happen in that manner as well. So you can tell the patient, oh, you've been coughing for so long, as the chest, then you can show the chest x-ray, like, the chest x-ray shows this. I think it's, you have fluid in your lungs. Again, you must not use a non-jargon, obviously. So we think that you can see there is some blurring here and here, and we think that you have some fluid in your lungs. That's what's causing you having breathing difficulties. So what's the next step that we will do is we will have to admit you, we have to give you some medication to remove the water and that sort of thing. But it's very obvious, very common in final med exam. Nothing rare and wonderful and that kind of stuff, okay? Can be a pneumonia, can be a lung cancer. Yeah. All discussed with the examiner. Yeah. So type 3, I think it's the easiest if you have a proper structure like memorized in your head and you're very good. You must practice this again and again. Best if you have your friend to help you. If not, you can do it on your own. Yep. For A to E, you must do it A, B, C, D, E. Do not jump from A to C and then D and then back to B. Never ever do that. You will fail it. Do A, B, C, D, E. Okay? Like I said, Geeky Quiz has very good resources because Geeky Quiz is literally OSCE station resources, so you can practice as it is. Okay, it's not just like books where you just read the A, B, C, D, E, that kind of stuff. Vocalize everything as you're doing, show everything as you're doing, always escalate everything. I will inform my seniors, I will escalate. Yeah. So I'm just going to give you an example of how I compile and learn my own ABCDE in the last 1 month. So yeah, so just a case, 57-year-old male with a past medical history is unknown. He just came in the A&E, okay? But he has a known peanut allergy. So very obviously, this is seems to be anaphylactic shock. So don't think too much. It's usually very obvious. The diagnosis is very obvious. So, and I'm just going to take it as it is anaphylactic shock. So my way of doing an ABCDE is first, I will take initial steps and I'll prepare to do the ABCDE. Okay. Then I will go in depth one by one shortly. So then I will do my airway, breathing, circulation, disability, exposure. And then I will complete with a reassessment of everything again. And then once the patient is stable and whatnot, I will do a referral or handover, or I'll just escalate. Okay. So there's A, B, C, D, E. Okay. In each of these heading, I have this that I will do. Like it's just my thoughts, right? Airway, when I get to airway, okay, airway. First, I will assess the patient's airway. Then I will do any investigation for the airway, if there is. Then I will do intervention for the airway. And then I will reassess if the airway's intervention was successful or not. Same goes for B. I will put all this in, assess the breathing, the lungs, investigate SpO2, respiratory rate, intervention, give oxygen, NAP, IV antibiotics. Yep. Fourth, reassess. Did the patient SpO2 increase? Did the RR drop? Same thing. Circulation, disability exposure, same. Okay, so initial steps and preparation. Very simple. Introduce yourself. How are you? My name is Dr. Abigail. I'm here to help you. Can you tell me your name and where you are now? So if the patient can talk, the airway is fine, right? So you already gain your airway information that you need. Then you can also ask the paramedics. There won't be paramedics and other team members around you, so don't worry, but you just do it so that the examiner knows that the examiner knows that you know stuff, like you know your stuff, okay? So you can say, I want to ask the paramedic what has happened. I want to see the ops chart that has been done so far. I want to see his prescription so far and whatnot. And then I want to ask other team members to help. I want to have a nurse with me to help me. Yeah, so it just shows that you're ready and prepared to do the ABCDE. So for airway, This is my way of doing it. You can always do it your way. I'm just like sharing with what I find is the most effective for me. So airway, clinical assessment, can the patient talk? Yes, the patient can talk. Is the patient sinus, mouth, tongue? Is the patient using accessory muscles and any foreign object? If no, then you can just move on. I couldn't find any specific investigations for airway, but I could do intervention, which is head tilt, chin lift, is an intervention for airway. You can insert an NPA, OPA, and then if you think that the airway is closing already, call NS help, would be in this step. After assuming you've inserted an NPA, OPA, or whatnot, then you will always want to reassess if the intervention was actually successful or not. So, check your vitals. If is it improving? ABG, is it improving? Is the patient still confused, less in pain, or patient is improving? Moving on to breathing, same thing, clinical assessment. Breathing is to do with the lungs. So clinical assessment, do a respiratory examination very quickly, chest expansion, trachea, percuss, and listen. Vitals. So investigation, there are loads of investigation you can do for the lungs and breathing. Basic would be ABG, do a chest x-ray, sputum culture, and PEFR for asthma. Intervention, 15 liters non-rebreather mask, put the SpO2 monitors. If the patient asthmatic, give a NAP salbutamol. For this, you don't have to check the BNF. You can just say that you want to give. You don't even actually have to give the dose because it's FY1 level. You just say, I want a NAP salbutamol or ipratropium or whatnot. Then you can just say, I want to give IV antibiotics. And then if the patient deteriorates, I want to do just start CPR right away. Don't wait until you finish C, D, E, then you start CPR. Okay. Same thing. After every intervention, after doing your intervention, you want to reassess the patient. Is the vitals improving? How is the ABG? Is it better? Is the patient still confused, less in pain? Same goes for C. Same thing, C. Do a cardiac assessment, cardiac physical exam. Okay, do your investigation. What's the investigation that you can think of that's related to circulation? Would be like full blood count, urea in electrolytes. Okay, LFT, coagulation screening, septic screen, group safe and cross match if the patient is bleeding out. Troponins is for heart attack, ECG also for heart attack. Okay, moving on to the intervention. So think about it, circulation. So what is circulation? 2 large bore IV cannula, you're going to put fluid into his circulation, right? 500 ml, 0.9 normal saline bolus step if the patient is acutely bleeding out. So when you put in fluid, you have to see if it's adequate or not. So how do you monitor? It's by putting in a urinary catheter and see the input-output. So if the patient is producing enough urine, adequately more than 0.5 ml per kilo per hour, so that means the patient is it's adequate. Okay, but normal, there is a difference between the minimum requirement of acceptable urine output, that's 0.5 ml per kilo per hour. The normal urine output would be 1 ml per kilo per hour. Okay. Then intervention, again, analgesia, because if the patient is having a heart attack, give analgesia. Just say morphine. You don't even have to give the dose. Think heart attack, Mona C. Then you can give furosemide if the patient is having heart failure. Again, patient crashes, do a CPR straight away. Same thing, always reassess after you've done an intervention. Otherwise, how would you know if the intervention is working at all, right? So vitals, ECG, do it again, repeat your ABG, check the urine output. Is it improving? Is the patient still confused or in pain? Okay. Next, disability. Disability mainly concerns like the patient's consciousness. This is what I got from my own learning. So AVPU is a very easy scale to use. if in an emergency to see how responsive is the patient. You can also calculate the GCS and check the pupil reactivity. So some of the common investigations you can do is capillary glucose. What if the patient is hypoglycemic and it's the thing that's causing them to lose consciousness in this acute event? Check for ketones in the event of DKA. Intervention, try to maintain the airway in the case of anaphylaxis. Anaphylaxis, again, IM adrenaline. If the patient had an accident and he's in the hospital now, so do you need to do a CT head? Yeah, just say I would like to call my senior and ask if the CT head is warranted or not. And then keep the patient NPO, CPR if the patient crashes again. Reassess, same thing, just reassess. Yeah. Exposure, now you've done everything that you can to keep the patient stable. Now you have to look for where is the source of infection, are there any other injuries or any site that is bleeding. So, and specifically for anaphylaxis, look for rash, facial angioedema, and then swollen and tender calf is for DVT. So if a patient comes to you with massive PE or any pulmonary embolism, so you want to look for the source of the emboli, look for the calves if they are swollen and tender. That might be the place that's throwing off the emboli. So investigations, of course, you're looking for an infective source. So you should do blood cultures, urine culture, wound culture. If there's any other bleeding, control it. Calculate the Well score. This is with regards to PE, pulmonary embolism, sorry. More than 4, order a CTPA. Less than or equal to 4, get a D-dimer. Same thing, intervention. Remove any allergen or precipitating factor. Stop any bleed. You can apply pressure. Okay, then if it's a pulmonary embolism, enoxaparin or thrombolysis, patient crashes, do CPR. So reassess, check the vitals and see if the patient is okay, doing better or not. So the last step that I would do, the last 2 steps that I would do is reassess the patient from top to toe all over again. Like just look at the patient. After you've done so many things, look at the patient from a whole. Are they improving or not? Okay. Last but not least, referral and handover. I don't think they will put this in the same station as the A to E assessment because there's no time. You only have 9 minutes. So if they ask you what are you going to do next, you can just say, I'm just going to refer or hand over or escalate. Okay. So referral can be a station on its own or handover. That will be it. I will talk more about this in the second NCA lecture. So I'm just going to briefly show you guys what I use. I use ISBA. I'm sure every RCSI student knows what's ISBA. So basically it's to identify, ISBAR stands for Identify, Situation, Background, Assessment, and Recommendation. Okay, just you can use whatever that you're confident with. You can use any handover tools, but RCSI teaches this the most. Yeah, so for acute cases, I've put together a table of what commonly comes out. So I actually studied all of this in preparation of my NCA exam this year. So you guys can just refer to this table and just like tick box that you've studied and know what are the general common acute management of these cases. Okay. So 5th, surgical and perioperative care. So you are not expected to know how to do the surgery or whatnot. Okay, you are just merely there to explain the procedure to the patient and answer whatever questions they have. It's as simple as that. Okay. So yeah, like I said, explain the operation, answer their questions. They are very good SPs, very kind, very nice. So don't worry, they're not going to just suddenly explode at you for saying you need surgery, and then like, why do I need it? They'll just say, oh yeah, I know the last doctor told me that I need, but I have some questions for you and whatnot. Very nice simulated patients. So I've come up with this list. This is how I like to organize when I explain a procedure or when I explain the operation to the patient, I will explain to them what is the pre-op preparation. Like the pre-op, for example, is you will have to come in to the clinic about 2 to 3 weeks before to attend a pre-op assessment. We will check whether if you are fit for the surgery. We might take some bloods and some chest X-ray, but we will decide on that day to see if it's needed or not. And then on the day of the surgery, you will come in the morning, and then you will have to fast for 6 hours for solid food and 2 hours for liquids. Yeah, that kind of things. That pre-op, what is it? Okay, then you go into the second thing that you explain to the patient is the operation itself. So assuming all the procedure, actually it doesn't have to be an operation, all the procedure like a gastroscopy or GDS, okay? So you can just say like operation, first there's two ways of a appendicectomy. You can do it either via keyhole or you can have an open surgery. Yeah, just like, and then usually keyhole is being done nowadays because it's faster healing, less pain. The surgeon will put in 3 ports here, here, and here, and whatnot. Okay, but then you must also remember to tell them there is always a chance of converting it to an open surgery if it's very complicated. The appendix is very complicated and messed up inside. Okay, you must always tell them that. Post-op, then you tell them after your surgery, we will bring you to a recovery room. We will monitor your breathing, your heart rate to make sure that you are okay from the surgery. After that, we will bring you up to your ward. You will be able to rest. We will give you painkillers to manage your pain. After that, the next day we will get if they're doing a orthopedics procedure, then you say the next day we will get the physiotherapist to come and help you walk, to teach you, like give them a preempt them what is going to come, like how you're going to take care of them and whatnot. Okay, then most likely they will ask you about recovery, honestly. So the most common recovery question is driving, when can I work, and when can I have sex? Okay, so all of this information you can find on the NHS website. Just type NHS gastroscopy procedure. All the information is there. If you can memorize that whole page, you can basically do this. Okay. Driving, yeah, you will be able to go back to drive when you can comfortably do an emergency brake. You can go back to work like about 4 to 6 weeks, depending on what operation that has been done. You can have sex usually when you are able to exert yourself without causing pain to the wound and whatnot. 4 to 6 weeks kind of thing. So look at the NHS website, see what is being said there, and that's your most accurate resources that you have, and it's all in layman terms, so you can actually just literally copy what's on the website and then like just organize it and just tell the patient in the exam. Some of the very common topics that usually occur in the exam is TURP, gastroscopy, colonoscopy, hernia, knee joint replacement, carpal tunnel, knee arthroscopy, cholecystectomy, hip joint replacement, and cystoscopy. Okay, I know it's already 7. I just have a little bit more. I'll speed it up. Sorry. So don't go into the details of we will cut your knee from here to here. We will clear the inside. We will core it out, and then you are just going down a rabbit hole. You have only 9 minutes to explain all of this information. Just say the operation is a small cut at the side of your leg. The surgeon will go in, clean out the damaged part, put a new fitting, a metal plate inside, and then we will make sure it's working, and then we'll close you up. Don't go into the details of it, because first you will have to start. If you say the wrong thing, they will penalize you. Secondly, don't go and learn. It's not the time for you to like learn and memorize how to do a cholecystectomy. You do that later on in your career. 6, discharge planning. Again, I think RCSI has trained us quite well in doing discharge planning. So normally is you take a discharge history. Basically, it is a very, very detailed social history. So you take like a 9-minute social history. Then you will they might have questions on how is their ongoing treatment going to be like, because you're discharging me and whatnot. Then you must be able to identify if they have any social issue. Usually they'll put 1 or 2 social issues in this station. Like the patient is living alone, she's 80 years old, and now she's had a knee replacement. How is she going to cook, clean, bathe herself, and shower? You see, that's a problem. So in this, think of a MDT, multidisciplinary team. I think you can see the circle in it. So the patient is in the middle. Okay. Think of all the MDTs that you can think of, such as you are one of it. Then you have your registrar, occupational therapy, physio, nurses. DISCO is called a discharge coordinator. They have this thing in the UK. So basically, they coordinate discharge. Okay. Social worker, nursing home, speech and language therapies, palliative, or learning disability. So keep this picture in your head. Okay. You can think of what services that they offer, and then you can try to relate it to your OSCE STEM, like your OSCE scenario. Okay, like if the patient had a stroke and they are going home now, but one side of their hand is like paralyzed, right? So you have to think, like ask them, do you have any difficulties now? Like I can't swallow properly. Then yeah, then you will have to say that I'm gonna like involve a swallowing therapist for you. We'll try to arrange them to come and teach you how to do it before we actually let you go home. Then if they had a knee operation, then you say, oh, actually we will give you we will tell the physio to teach you how to do exercises and whatnot. Okay. Yeah. So I have distilled down the questions that should be in a discharge history. So basically, it's a social history that you have to do it very in detail. So tell me, how is your living conditions? Where do you live? How do you sleep? Are you able to use the toilet and bathe yourself? If they say no, or they said I don't know, you can say I can ask the occupational therapist to assess you and see if they can offer any services to help you. Okay, then you must ask, how's your diet? Like think of it like yourself, you're an 80-year-old going home after a big surgery. Like think about the practical things while living, eating, bathing, moving around is these are the basic necessities of life. So think about it, and then you will be able to formulate what questions to ask. So ask about, how's your diet like? Are you able to prepare meals? So they can also say, they can tell you, no, I've only been eating microwave meals. It's a very common thing in the UK for them to eat microwave meals, actually. No, I've only been eating microwave meals. My son buys it for me. He's very busy, he's working, so there's no one to cook. So this is a problem. You can say, I will speak to the discharge coordinator and see if they can arrange Meals on Wheels. Meals on Wheels is a service where it's a worldwide service. So they have this in the UK, where they will deliver meals, like cooked meals, to people who need it. So the discharge coordinator might be able to help with this, you see. So that's why you have to ask a good social history. Otherwise, the discharge coordinator wouldn't know that the patient is on microwave meals. Yeah. Ask about smoking status, alcohol, illicit drugs. If you have time, you can just say, would you like to quit smoking? I can help you. But don't go into quit smoking now. This is not the station for it. And then you can ask, how's your mobility? Do you need a walking aid and whatnot? So these are some of the important things to note in the discharge history. If the patient is smoking, you cannot let them bring home the risk of oxygen therapy, because there was actually a case in the UK where they took home and then they lifted it up and then the oxygen tank exploded. So you must ask, are you smoking? And then if they ask, oh, I also want to have oxygen at home before my COPD, but then if they're smoking, you are not allowed to give them. Okay. And then if a patient needs a walking aid, like a wheelchair or a walking frame, you can tell them you will try to get it for them. Don't promise them, because you will get yourself in a rabbit hole. Then you can say, I can get the team to assess you and see if they can arrange for you a wheelchair. Like I said, don't promise anything that you are unsure of. Okay. So I have a scenario, but I think we've run out of time. So anyway, the scenario is just Jane Smith is an 88-year-old lady who was admitted for the 4th time for AECOBD. The consultant has told her that she is medically fit for discharge. Jane is very concerned and wants to speak with you. So speak to the patient regarding their discharge and answer any questions that they may have. So the OSCE station would usually be framed in a very short, in this manner. It's very short, very direct kind of instructions. So yeah, you guys can have a try, or if you want, you can reach out to me. I can also like just do a little role play if you want to. So yeah, thank you for attending today. I know I've overrun my time by 7 minutes, so I hope this is useful to you guys. So do you guys have any questions? Okay, if there's no questions, then I think we'll just call it a day. So thank you guys for coming today. I hope this has been helpful. Thank you.